Greetings. My name is Elena Kennedy. I'm the Chief Operating Officer here at IAMHP, and we are so excited to have you on today's presentation. For those of you who are listening live, I'm going to go through a few logistics that will be your window to interacting with today's webinar. As you can see, IAMHP utilizes the GoToWebinar platform for all of our webinars. To interact with today's presentation, you will utilize your control panel. The control panel should have popped up on your right-hand side. Due to the large volume of attendees today, we will not be unmuting everyone. We're going to go through a few ways that you can interact and still engage with the presentation without actually speaking. Once again, due to the high volume of attendees, there may be issues regarding audio. With that in mind, we are encouraging you to dial in utilizing your phone. If you are hearing a cancel sound or a busy signal, you can also call in and listen in via your computer. You will be in listen-only mode for both versions. Should you or your colleague have any issues or technical difficulties with audio, please submit those questions via the Questions tab on the control panel. If you locate the Questions tab on the control panel now, you can submit questions to the entire group by clicking Send to All or Send Privately, and those will be directed to myself, Elena. I might be showing up as IAMHP admin or organizer on your end. We will not be having any poll questions today, so you can ignore that. Below, we do have a few handouts. Due to some privacy or firewalls, your computer might not allow you to download the presentation, but do not fret. We will be circulating both a recording of this presentation as well as the slide deck around to everyone after the presentation. Thank you once again for listening to the logistics. If you are having any issues with technical items or would like to ask questions as we move along, friendly reminder, everyone will be in listen-only mode and they can submit questions and chats on the side. Without further ado, I am going to introduce our presenter today. Samantha has nearly a decade of experience in healthcare and appropriations policy, and as Executive Director and Chief Executive Officer at IAMHP, she is responsible for coordinating legislative strategies, testifying before legislative committees, and working closely with state agency administrators to formulate and implement policies that positively impact members. She's been working tirelessly on policy and agenda items as well related to COVID, and we are so excited that she is bringing her expertise today to talk to all of us about Medicaid managed care telehealth expansion during COVID-19. Without further ado, I am going to kick it off to Samantha Olds-Fry. Samantha?
Good afternoon, and thank you, Elena, for going over logistics. This was a very kind introduction. And thank you to all of our participants today for joining us during this very busy time to use this resource to further your understanding of the telehealth billing expansion as it relates to Medicaid managed care. I do want to cover just a few basics. IAMHP, or the Illinois Association of Medicaid Health Plans, has 7 members. We represent the full industry of Medicaid health plans in the state of Illinois. We are today talking about Medicaid telehealth expansion, and for that reason, it will just apply to our health choice plans. As you know, Medicare has also expanded telehealth services during COVID-19, and MMAI plans function as Medicare primary, Medicaid secondary. And so for MMAI plans, they'll be following Medicare guidance. What we'll cover today is for Medicaid, and there are some nuances there, and so we just want to really emphasize that this is about health choice and Medicaid as the primary payer. And with that, we'll dive right on in. All of these policies and what we're covering today do impact providers across our great state. All 102 counties have health choice membership in them, and so this covers the full state. And we want to just start with some basics, some things that you guys might already know regarding telehealth before we talk about some of the expansions. But we want to just really make sure that we have that level foundation, because a lot of you as providers didn't previously bill telehealth. And so while you may have been an eligible provider to provide telehealth services, you weren't utilizing that because you were interacting with your patients and your members face to face. And now, in light of COVID-19 and the public health crisis we're all facing, that's not always viable. And so these resources will be helpful to you, even if you were a provider who was already eligible to provide telehealth services. And so with that, our first item, IAMHP has created a telehealth billing guide that can be found on our provider website. It's in the right-hand side on the resource guide. We sent it out last week, but it is there as well. That is very helpful because it goes through examples that are both existing coverage, because as you know, anything that was telehealth services that Medicaid covered prior to the COVID-19 crisis, all of that is still intact. If you were billing telehealth prior to COVID-19, nothing has changed. It's just that there have been additions, there have been expansions, there have been addition of codes, there have been expansion of providers that can bill telehealth, and there's been expansions of where a member can be to receive those telehealth services. So that's what we're going to cover today. This is simple, but we just want to make sure we remind everybody all services that are billed and provided via telehealth must be clinically appropriate to provide via telehealth. So what does that mean? It means you can't provide brain surgery via telehealth. You guys know that. If it's a service that isn't clinically appropriate to provide via telehealth, if you need to be physically engaging with the member, then you need to be physically engaging with a member, and telehealth services really are just for those services that can be clinically appropriate via telehealth. This is something that's really important as well if you are not used to telehealth services. Unlike face-to-face services, telehealth services may generate two claims. One is for the originating site. That's where the member is located. And the second is for the distant site, wherever the clinician is located. So to break this down further, if a member is in a nursing home and they're receiving telehealth services from an FQHC, then the nursing home is the originating site, and the FQHC where the doctor or nurse is located is the distant site. Distant sites will use the GT modifier and the 02 place of service. That is the foundation of how you bill for telehealth. As the distant site, you are going to bill the regular HCPCS codes or CPT codes that you always would. And the only difference of a face-to-face visit versus a telehealth visit for your regular services is the GT modifier and place of service 02. Place of service 02 lets us know that it is happening there via telehealth. So even if you are located physically in a clinic, or maybe you're at your house as a clinician, or you're at a hospital, or wherever you may actually be as the distant site, the place of service is consistent, and it is always 02. The second item is that GT modifier, and that GT modifier also indicates that this is a telehealth service. It's really important that we acknowledge that Medicare, commercial insurance, other services have various modifiers. There are other telehealth modifiers out there. In Illinois Medicaid managed care, we are only utilizing the GT modifier. And the reason is, as we expanded telehealth services, we did not want to change how any existing provider who was providing telehealth services was billing. So those other modifiers were not previously accepted. And so we didn't want to add confusion during this time period. And so because of that, it is just the GT modifier. There is not the menu of modifiers. It is just this single modifier, and it is just this single location or place of service 02. So that's consistent. Let's dive on a little further. Equipment you need. Now, this is a real change. Previously, when you were providing telehealth services, it needed to be HIPAA compliant technology or platforms. There previously needed to be a doctor present at the originating site. Or a clinician. That has changed during this time. So obviously, first and foremost, visual and audio is preferred. You're going to have a better interaction if you can see the member you're meeting with or the patient. Skype, FaceTime, Zoom, etc. Anything that is one-on-one is accepted. Video, so if it's public facing, and other people can see the interaction, that is not accepted. But if it's just you and the member or the patient, that's when that platform can be acceptable. Telephone is accepted when it is appropriate. The big one here is going to be, behavioral health services. Again, audio, visual, always preferred. Better, just a better visit and a better engagement. But if it's not feasible, then a telephone connection is accepted. And then, of course, full telehealth equipment or coordination between the originating site and the distant site may provide a more comprehensive appointment. And it is something that, we still see as a recommendation, especially for those specialty services or those more chronic members, of fuller visit, where you're able to monitor somebody's blood pressure, you're able to monitor some of these other, other health indicators, are going to provide you obviously a more comprehensive visit. And so where feasible, that may give you a fuller picture of a health condition. So what did we change to Medicaid telehealth coverage? First and foremost, this is different than Medicare rules. So I'm going to try to flag where things are a little different, but we'll have some time during the question and answer section to discuss that as well. But under Medicaid, you no longer need to have an existing relationship with a member to provide telehealth services. So you can use your telehealth visit to establish a relationship. We've expanded providers. PT, OT, speech therapy, dentists, and behavioral health providers are now able to provide telehealth services. Again, this is an expansion. Medicaid now covers various services that weren't previously covered. These are G codes. They are the virtual check-ins, the portal or e-visits, remote evaluation, and we'll go through all of those as well later. And then members can now receive telehealth services while they're located at home, whatever their home may look like, whether it's a nursing home, a supportive living facility, a private residence. The state has expanded where a member can be located for telehealth services during this time period. Now we're going to talk about originating site billing. I just want to remind everybody that telehealth, two types of claims. The first is the originating site claim, and that's what we're going to talk about now. And then we'll transition and talk about the distant site billing. So first and foremost, one more reminder, the originating site is where the patient is located. So because we've expanded where the patient can be located, there's some new billing updates regarding how you bill as an originating site. The first is for our hospice providers. You're going to use revenue code 0657 in conjunction with HCPCS code 3014. So that is guidance specific for hospice providers. Hospital billing requirements for telehealth have not changed with regards to the originating site. So everything that's in the handbook, everything that you've historically been doing as an originating site, that's still consistent. Nothing has changed. You don't need to change anything. Practitioners' offices. If the member is physically in your office, and this could be, practitioner of physical or mental health, you're going to use that HCPCS code 3014. And that will generate your facility fee. The Illinois Medicaid facility fee is $25. The place of service should be where the member is located. So are they at a mobile unit? Are they at the FQHC? Or are they at the nursing home? And so when you look at our comprehensive telehealth guide, we list out the various places of services and the various codes based off of the place of service to make that easy for you. So the number associated with each location. We are anticipating and working with the department for more guidance regarding other facilities, such as nursing homes, SLFs, residential treatment, etc., and the revenue codes that should be utilized to get that $25 facility fee, and those are forthcoming. However, do know we will be reimbursing for those services, so do not hesitate to begin having members receive telehealth services only because that billing guidance for that originating site information has not been found. Go ahead and get your members the care they need, and then we'll provide that guidance and those details for you. They are very forthcoming. If the originating site is the patient's home, there's not going to be a claim for the originating site to be submitted. A member is not going to be submitting a claim, as one could imagine. So that would not apply to this newest our newest place of service. Of course, when we say home, what we mean there is that private residence. If they're in a nursing home, if they're in a SLF, then there are other rules that apply. I do want to highlight here some differences or some nuances that are specific to encounter rate clinics. These are our FQHCs or rural health clinics, etc. When ERCs are serving as the originating site, they first bill their T1015, then they bill their HCPC Q3014, and this is really different. Unlike other originating sites, when an ERC will be paid their encounter rate, and then the ERC is responsible for reimbursing the distance site. So that has always been the case. That has not changed during this process. We just want to make sure that given the expansion and the new utilization of telehealth, that we just remind everybody of current practices because this is new to a lot of people, even though these policies are not all new. So distance site billing. So this is where, again, this is the second claim. This is the claim that is associated with where the clinician is. And so we're going to dive right on in. So again, the distance site is where the clinician is located. Providers follow your standard billing practices. Billing with an impact registered provider, only billing for HCPCs or CPT codes that are covered by Illinois Medicaid. The standard practices, how you are billing face-to-face, is how you should be billing for telehealth with two changes. So first, the first change is your place of service. It is 02 when you're serving as a distance site, regardless of where the member is located and regardless of where you as a clinician are located. Your place of service 02. Second, go ahead and use that GT modifier on all service codes, all service lines, all detail lines, whatever your nomenclature is on each of those codes or details, use that GT modifier. I'm going to talk a little bit about some uniqueness. Again, encounter rate clinics, you guys are a little unique, so we just want to highlight this. For encounter rate clinics, you bill. If you're the distance site, you're going to bill that T1015 code, modifier GT, of service 02. Okay. For mental health, and this is different, you are going to bill your key code first. Then, also first, you are going to use your behavioral health modifier. This has to be first. Bill your behavioral health modifier, the appropriate one based off of the clinician. Bill that first. Then bill your GT modifier. The place of service should be 02. This has always been in place. This is not a change, but because there are new new providers who are billing,
wow, that was fluff.
it is very important that we just emphasize this, because if you don't bill that BH modifier first, there's going to be an issue. Dental telehealth services. So this is a new service.
How do you do dental health over
there are two codes that are allowable under telehealth.
They can tell you anything, you have no basis.
The first is D999.
Apologize, Samantha. Everyone should be in listen only mode, but we apologize. There is some background noise. Just as a friendly reminder, please mute yourself. We have someone who's dialed in and I do not have access to mute them. We apologize for the inconvenience. With that, Samantha, you can continue.
Great. So there are the two codes, the 9995 or the 9996. You're going to bill that in conjunction with 140, which is the partial exam. You are not, unlike other providers, going to use that GT modifier for dentists. And the reason is that the dental modifiers are all based on the location of the tooth. GT is not going to help you there. So don't use the GT modifier, but you are going to use that place of service 02 to indicate that it's a telehealth service. And those D codes, those 9995 and 9996, are already codes that are telling us they're happening via telehealth, so we'll be able to identify that. Super guidance. So this is very important. We're going to walk through probably one of the items or the two items that I get the most questions on thus far right now. So first, Super did put out guidance. All the Medicaid health plans are following it on the services and the corresponding activity codes that are billable to Medicaid for telehealth. So it's these services, individual therapy, continued stay review and discharge planning, treatment, psychiatric evaluation and medication monitoring, admission assessment, and discharge assessment. The same rules apply to face-to-face. If this needs to be done by a physician or a certain level of provider face-to-face, then that's still required when it's provided via telehealth. That has not changed. The second thing is, much like for all of our other providers, the HCPCS codes or the CPT codes that you are billing when this happens face-to-face, you're still using those HCPCS codes and those CPT codes when you're billing for telehealth. None of that has changed. Here is what has changed. You are required when billing Medicaid health plans to use that GT modifier and that place of service 02. And I want to talk about why. This isn't simply because the health plans wanted to be difficult or they wanted to make you guys do something that was different than fee-for-service. It is further from the truth. These services are being expanded to be allowed via telehealth. And that means that there can be, and we anticipate there will be, originating site claims coming through for these services. Members in nursing homes, members in residential treatment facilities who are now getting their individual counseling via telehealth due to the public health crisis, that facility is going to be able to bill that originating site claim. They're going to get that. They're going to be eligible for that facility fee. The issue is, if you were to bill a health plan without the place of service 02 and just use your regular place of service and not use the GT modifier, you are billing that health plan as though that service took place face-to-face, that interaction was happening in person. So when you tell a health plan that and you tell their claim system that, then they're not anticipating an originating site claim. Why would we? There was a claim associated with being face-to-face. There should not be an additional claim. When you have a face-to-face visit, there's only one claim, not two. So we want to make sure that we're able to reimburse all providers appropriately and that nobody is, in danger of any audit issues, that nobody's in danger of any recoupment because we don't see a corresponding telehealth visit. We want to make sure that this is something that we can fully monitor, that we can implement appropriately. And because of that, the health plans need that place of service 02 and that GT modifier. The last thing we want is for the systems to not believe that a telehealth visit took place when it in fact did. So you can absolutely, as a provider, still provide services face-to-face. And when you did that, you would bill as though the service happened face-to-face with your regular place of service and without that GT modifier. Those claims are still absolutely being paid. But you can't bill telehealth services like that, because if you do, you're jeopardizing the rest of the provider community and those originating site claims. And so we just want to avoid audit findings on the front end. We want to make sure that we are able to implement this not only now simply, but in the future. And so that is why we're requiring that GT modifier and that place of service 02. And HFS systems are unable to, on Super, accept 2 modifiers. And so that is why they're not able to make that change. And so there is that difference, and we understand that that can be a cause of frustration, but HFS systems aren't able to change on how they process as quickly the telehealth claims. And so they are not doing it, but the health plans do need to do that to just make sure, again, that we're not jeopardizing anything, that those facilities that are doing a lot of work right now, that we're not jeopardizing any of the revenue that they should be receiving. So CMHC and MH guidance. So again, this is already out there, but it's, basically it's group A, B, and C services, except for group psychotherapy, mobile crisis, crisis stabilization. And again, if you're a CMHC or a Super or a BHC, we are requiring that place of service 02 and that GT modifier. This is to make sure that originating sites are paid appropriately. You can, as a provider, still provide services face-to-face and still bill face-to-face. But if you're billing via telehealth, we're asking for these indicators to make sure we can pay our originating sites appropriately. The other thing that plans are really doing right now is that we're looking at all our claims data to understand, to assist in our care coordination, to make sure we know, where members can still get services face-to-face, what providers have expanded telehealth. And we need this accurate picture to make sure that we are coordinating appropriately. So new codes, when to use them, what they are. So these first 2 codes, it's really important. These are for established patients. And as we walk through them, it'll make sense of why they're for established patients. There are also limitations on who can provide these services. These are limited to physicians, APNs, and encounter rate clinics, and the like. So the first is our virtual check-in. This is the G code 2012. This is a 5 to 10 minute medical discussion done telephonically. It's not originating from a previous visit. So if you had a visit 6 days ago and then you call the patient, that's not a virtual check-in. This would be, you met with them a month ago, you want to check in on them, and it doesn't lead to an EM service within the next 24 hours or soonest available appointment. So it's also not scheduling a future appointment. This is a check-in. How's your blood pressure? How's your sugar levels? Etc. Do you have access to medications? All of those items. So it's just a check-in. This would be really recommended for those members with chronic conditions. Do they need anything right now? G2010. This reimburses for virtually reviewing images or recorded video. So what would you be looking at? That's going to be images of rashes or recordings of coughs, bug bites, etc. So this previously was not reimbursable. Now it is. The idea being we want to limit physical interaction. Are there ways to enhance that? And this G2010 code is one of those ways. Again, same rules as the G2012. It can't be a follow-up from a previous appointment within 7 days. Oh, and it cannot be it cannot lead to an appointment 24 hours later. And finally, I just want to remind you again, this is for established patients only. Our portal or our e-visit, again, established patients only. I like to think of these as the chat function with your clinician. You first and foremost, in order to bill for either one of these codes, you have to have a portal that has this functionality. You cannot bill for these HCPCS or CPT codes if your portal doesn't allow you to function this way. So the two sets, the G codes and then the CPT codes, they're all for the same service or same sort of activity. The variance is how long they are. So the first is a qualified non-physician healthcare professional online assessment. This is a chat for up to 7 days where your cumulative time during that period is either 5 to 10 minutes, 11 to 20, or 21 minutes or more. The next one, the CPT code, so this is the 99421 through the 423, online digital evaluation management service for an established patient. Again, chat function up to 7 days, so back and forth. Cumulative time during that, either the 5 to 10, 11 to 20, or 21 or more. So again, if you've engaged with a doctor like this, it is that sort of that back and forth process. It can be inquiries of, do I need to go to a doctor? It's various health inquiries. The payment is based off of how long the service took, what that work effort was. Remote inpatient and ED evaluation. So again, this is a new service, direct response to COVID. The recognition that we may now want to limit additional clinicians that are going to a hospital setting. And so these services are there to assist in that. So these first three, the G0406 through the 408, same thing. It's just the time period. So it's the same service. That's the follow-up inpatient consultation. And then the timing is how long it took. So you're going to use that 406 if it's 15 minutes. You're going to use the 408 if it's 35 minutes. Or, then we have our G0425 through our G0427. Again, same service, just the time period of what you would bill. This is going to be your telehealth consultation for ED or initial inpatient. And if this is just a communication via telehealth. We wanted to make sure why this is on here. We wanted to make sure that especially for those immunocompromised clinicians, that there is a way for systems and providers to continue to engage and use those resources of those providers, but also maintain their safety. So for all of these, there is a theme. Use the GT modifier and the place of service 02. That is consistent for all of these new codes. So whatever it is, go ahead and use that GT modifier and that place of service 02. I also want to pause here and say that for all of these services, that all of these expansion, and this is highlighted clearly in the telehealth guide, but I want to just make sure that you guys know it as well, that during this initial time period, health plans are reconfiguring to accept or pay these new claims, to process these expanded services. And so because of that, you may receive a denial on the in this short period. All health plans have committed that if you receive a denial, they'll go back, they'll grab those claims, they'll reprocess them. You as a provider don't need to do anything. But if you were to bill one of these new G codes this week or next week, you may get a denial that says something along the lines of non-covered service, no fee associated with it, whatever it may be. They're working on it. They're going to pull it back. They're going to reprocess it for you. It's just because we felt it was so important that we got this guidance out there for you and that we didn't wait for the system to be all fully reconfigured, which can take a few weeks, because we wanted to make sure you knew as a provider these were the allowable services. You'll be reimbursed for these services, provide these services to our Medicaid members, and then we'll go ahead and we'll do the work on the back end to make sure you get paid. So if you get a denial on that front end, do not be alarmed. It is because of system. We are in the process of reconfiguring systems. We are working on it. If you have any questions, though, go ahead and reach out to your provider relations rep for any questions you may have. But do know that the plans have already committed to reprocess all of those claims once everything is up and configured. So additional resources that we want to highlight for you. So first is our key contact. IAMHP has always maintained a key contact web page. We've always had a resource that allows you to let us know if there is a change, to just let us know if somebody's not responding to you or somebody's left. Go ahead and let us know, and we will update that for you. During this time period, especially as you're all out of the office, or a lot of you may be working in just different manners. If you've lost somebody's contact, the contacts for the health plans are all on there, can be a really helpful resource during this time period. So we wanted to emphasize that for you. We also want to make sure that you know as we provide COVID updates and provide new information, we are sending those out via our newsletter list. And so if you are not signed up for our newsletter, you might be missing some of the notices. That's also how we're alerting people to the webinar, any complimentary webinars we're doing, or anything regarding changes in healthcare policy. So my recommendation is, if you want any of those COVID updates, go ahead onto our Insights page at our website, IAMHP.net Insights. You can just subscribe there. After we're past this public health crisis, if you aren't someone who still wants information from IAMHP on the work that we're doing, you can unsubscribe. But during this time period, I would recommend, if you want those COVID changes and updates, to go ahead and subscribe, just to make sure you're getting that up-to-date information. We don't share our distribution list. It's just us. So your information is not going to go anywhere. It's just to make sure that you're getting the information that you need in a timely fashion. We also have upcoming webinars that we are going to be doing. Our COVID webinars are going to be complimentary. IAMHP is funding those. We are using our resources to support all of the technology and then the education. So the first one is this one that's occurring right now regarding telehealth. We have one tomorrow on small business loans, resources that are available today, and what's coming out of the CARES Act. We do anticipate a follow-up small business loan webinar, and we do anticipate additional webinars as it relates to COVID, as more information is available, as things change, so that we can provide more information to you. Those will all be in our events section. If you sign up for our newsletter as well, you'll get those alerts as well. Like I said, we're going to continue to do those complimentary to make sure that we're getting as much information out to as many people who need it during this time period. I also want to make sure you guys have our contact information. Here are our email addresses. This webinar presentation is being recorded, will be posted on our website under our IAMHP video library. We will be sending these slides out to everybody who joined us today. We will also, in that email, send a link out to our other COVID material that we've published thus far. A big item that we've published on the telehealth billing is how providers sign up for EFT payment from the health plans, from all of the health plans, all in one single resource. During this time period, we are highly encouraging providers utilize EFT. The mail has been delayed. Not everybody is working in various locations, and so posting payment, receiving payment and posting payment are critical right now. And the last thing we want is payment sitting in a mail room for an extended period of time. We have looked at this, and Illinois providers, more than almost any other provider in other states, are more reliant on paper checks instead of EFT. So if you are not signed up for EFT, we just highly encourage you to consider that, and the resources on our website to help you do that for all of the payers. And with that, I did hit the mark I was hoping to hit, which is giving you guys about 20 minutes to type questions in, to provide some feedback and some engagement. Because of the size of our webinar, as Elena said, we're not going to be able to open it up. We have about 500 people participating, so we're not going to be able to unmute you all in order for a productive conversation. So go ahead and just type those questions into the chat function or into the question section. And Elena, I'm going to just ask if you want to kick us off with the first questions you've received.
Thank you, Samantha. Unfortunately, as our moderator, I have to do a check and see that we are only have 1 minute remaining. To those of you who had questions submitted, we are going to do our best to compile some of those and answer some of those offline. We appreciate you submitting those, and we also appreciate you attending today. Since we have 1 minute left, though, I want to kick it back off to Samantha, see if she has any closing remarks for us today.
I just want to take a moment to thank all of you for joining us, to acknowledge all of the work that you are doing during these unprecedented times, to remind you that IAMHP is here as a resource for you, but also somebody who, as an organization that is in appreciation of all that you do, especially when the way that you've always done things has completely changed. And you're being asked to do more than you've ever had to do, because our system and the over 3 million people who rely on Medicaid require that from all of us. And so I think that as we travel through these harrowing and daunting times, I just want to remind everybody, first, that you're noticed, that you're appreciated, and second, that to find solace in remembering why we're all here to begin with, and that's to serve the Medicaid members. That is to help people. That is why we all got into healthcare. And so you're doing that. We acknowledge and appreciate that, and want to be here as a resource for that. So thank you for all you're doing. Thank you for not losing sight of what is most important, our Medicaid members. And let us know if there's anything that we can provide as a resource to you.
Wonderful. Thank you so much, Samantha. And with that, we will be ending today's webinar. Thank you and have a fantastic day, everyone.